blew me away. It was so great, and I learned so much from it. And I'm certainly going to look for someone at our institution who has an interest in this. So the title of this is, Are FMD and SCAD the same disease? And I know this is controversial, and there's no absolute data to suggest they are or they're not at the present time. But I think ultimately, when the genetics of all this is worked out, I think it's going to be the same disease. And what I mean by that is that patients with FMD present phenotypically different. In other words, one patient may have an aneurysm and FMD, the renal arteries, such as this, what you see here, you see the celiac artery aneurysm, and you see beating of the left renal artery. And one patient may have arterial tortuosity and SCAD, and there's a lot of overlap between SCAD and FMD. In order to diagnose FMD, you have to either see the string of beads or you have to have a focal area stenosis. And I'm going to finish by showing you an example or two of, well, you can have FMD without those things. So we've already been through this: multifocal FMD, focal FMD, arterial tortuosity. This should be straight. This is a dissection with a pseudoaneurysm. Spontaneous coronary artery dissection. Dr. Kim is going to talk about this. She's one of the world experts on this particular topic. Aneurysms. So that's the phenotypic presentation, meaning patients can present with one or all of these things. And the genotypic aspect of these conditions is not yet known. In other words, it has not been worked out what the genes are in people with FMD or SCAD. We used to think it only occurred in the renal arteries, and then we learned it occurred in the carotid arteries. It's very common in the external iliac arteries. And now that more and more cardiac interventions are being done through the radial artery, we're seeing it in the brachial artery. And we routinely listen over the brachial arteries now for a bruit, you know, the sound that you all may hear in your ear, the whooshing sound. We listen over the brachial arteries. And I have two patients who had imaging below the groin who have FMD in the leg arteries, even the leg arteries below the knee. We just never look there. So this is an example of an MRA showing pretty significant multifocal FMD, the carotid arteries. We never used to look at the carotid arteries, so we thought it was really uncommon to have it in the carotid arteries. When we wrote this paper, we said FMD occurred in the carotid arteries 25 or 30% of the time, the renal arteries up to 75% of the time, and in multiple vascular beds, 28% of the time. Well, we now know that this is wrong. They occur about 70%, it occurs about 70% of the time in the renal and the carotid or vertebral arteries, and it occurs much more frequently in multiple vascular beds than 28%. You know, if you don't look, you're not going to see it in the carotid arteries. And the group from Paris who we collaborated with for years, I remember when we first went over there and showed like the prevalence of carotid disease in this, they started screening all their patients with it. Before, they were just taking care of the renal artery aspects of it. So there's still a lot of information to learn about this. What we saw in 447 patients is pretty much what we see in 4,500 patients, with a few exceptions. I'm not going to go through it all, but I'm going to go through one aspect of it. So the average age of diagnosis of FMD was 52 years in our registry in our first series. When I was a fellow, I was taught it occurred in 20 and 30-year-old, predominantly women. In our series, it occurs in about 95% white women, but that's because nobody looks in Black, Hispanic, or Asian. I have individuals I take care of all these ethnic backgrounds, and I don't believe there's a predominance of FMD in white people compared to others. In our registry, these were the four major presenting symptoms. Look at pulsatile tinnitus in 28% of patients. Patients don't volunteer that they hear funny noises in their ear. You have to ask them, do you hear any noises in your ear? And then what does it sound like to you? And if they can't really tell you, then I go a step further and I say, do you hear like a whooshing or a swooshing sound? Like, and many patients who thought it was normal would say, yeah, I do hear that. I've heard that for a long time. Emma Greenwood, who started the whooshers.com, put together the most incredible website you'll ever find for people with pulsatile tinnitus. One of her talks is going to be available as a pre-recorded talk. I've heard that talk before. It is really enlightening, and I would encourage you all to listen to it if you have time. The pulsatile tinnitus is common. Fortunately, strokes and TIAs are not common, and when they occur, they almost always occur in the face of a dissection. Not 100%, but most of the time. But look at this, MIs in our first 447 patients, only 8 patients. So you heard some of this from Daniela. This was our study, the registry study of our first 966 patients, looking at the prevalence of aneurysms. These are aneurysms in the renal artery, and 22% of patients had aneurysms. The most common was the renal, carotid, and intracranial arteries. And other places. This is a cerebral aneurysm. This is a woman who has a dissection here. This looks like FMD. It could be FMD, but it could be the healing phase of a dissection. And this same woman had this pseudoaneurysm. A covered stent was placed. You no longer see this part. The stent wasn't put in this part, okay? It was put like from here to here. And you no longer see that beating. And you see an aneurysm here in this tortuous segment. And I've been following this patient for a decade with this bi-tipped basilar artery aneurysm that has recently grown, is going to need intervention. And then in these 929 patients, dissections occurred in about 26. This is a carotid, this is a vertebral dissection. And coronary dissections only occurred in 10%, 24 patients. But I looked at our data from 2012 versus 2020. At that time, we had 2,733 patients. And I just want to point out one thing about this, that if you look at coronary involvement in the original paper, it was very, very low. If you look at coronary involvement in the updated paper, it was 27.6%. That means that we didn't even know anything about spontaneous coronary artery dissection in the period prior to 2012. It was almost always missed as a diagnosis, and patients were never scanned from head to pelvis who had this. And I think you're going to see this number go up in patients with FMD because I think it's a major component of FMD. This just shows you what the brachial artery FMD looks like in an angiogram and a duplex ultrasound. And a common finding that is frequently misdiagnosed is when you see a dissection, you may only see a long narrowing of an artery. This is a carotid artery. And this is a T1 weighted image. And all this material here, the white stuff, is blood. This is an intramural hematoma. And the blood is flowing through this little black hole. So the artery is severely narrowed. It's an intramural hematoma. You don't see a tear in the artery, but this is the same thing as a dissection of an artery. An intramural hematoma is the same thing and can cause the same problems with it. If you did not do T-weighted images, you would do T1 weighted images, you would only see this little narrow spot. So I am going to skip this, other than to point out that originally we thought 10% of patients had coronary involvement. We now know that 27.6% of patients with FMD have coronary involvement. Now here's a patient with SCAD. And when we did head to pelvis imaging, we saw this. This is exactly what you see in many patients who have fibromuscular dysplasia of the carotid arteries. This is not enough to diagnose FMD because you don't really see the beating, but this type of tortuosity with areas of narrowing and enlargement is very much what you see in fibromuscular dysplasia. And a more extreme aspect of tortuosity is shown here. Look at how severely tortuous these arteries are. And there's a syndrome called arterial tortuosity syndrome that has a gene associated with it, but that's very, very rare. I've never seen it. And this is just a woman who has very severe arterial tortuosity. So a consensus point from the international consensus document was this: regardless of the initial site of vascular bed involvement, patients with FMD, and I added here, or SCAD, should undergo imaging of all of the blood vessels from the brain to the pelvis at least once, and usually with CTA or contrast-enhanced MRA, to identify areas of FMD, as well as, more importantly, to identify areas of occult aneurysms, dissections, and other vascular abnormalities. So when you see something like this in a coronary artery, nobody misses this as a diagnosis of SCAD. This is, you actually see the dissection. And this is an OCT, and the true lumen, which is this narrow part here, is shown on this OCT, and the false lumen, which is this is really a pseudoaneurysm, is shown in this part. And when you see an area of normal artery, I don't care what blood vessel you're in, this happens to be a coronary blood vessel, the left anterior descending coronary artery. You see normal artery, long, smooth, narrowing, normal artery, that's always dissection. You see it in the carotid arteries, the renal arteries, any artery in the body, normal, long, smooth, narrowing, normal is a dissection. And this is spontaneous coronary artery dissection of the left anterior descending coronary artery. And this patient's blood vessels look like this. She did not have fibromuscular dysplasia, but she had severe arterial tortuosity and multiple arteries of ectasia, multiple segments where the artery is larger than it normally is, but not large enough to call it an aneurysm. That's ectasia. This shows that same slide that I showed you before. It shows you the various types of SCAD. I'm not going to get into that because Dr. Kim is going to get into that. But I want you to look at this image here. This is the right coronary artery. And most people would say you have the string of beads of the right coronary artery, but that's not true. This is a patient who had a dissection of the right coronary artery, and either during the dissection, there's spasm of the artery, or during the healing phase of the dissection, there's remodeling of the artery. So the string of beads is not really seen in the coronary arteries. The major manifestation of FMD in the coronary arteries is dissection. And it's very rare to see something like this. And this is not the usual string of beads that you see in other arteries. So SCAD is an arteriopathy. FMD occurs in 35 to 80% of people. It depends how careful you look and whether you're using MR or CT angiography, whether you're doing thick cuts or thin cuts. You've already heard it occurs in a large percentage of people. Intracranial aneurysms, arterial tortuosity is common both in the coronary and extracoronary arteries, supporting an underlying arteriopathy. This is from the Mayo Clinic series on the tortuosity, and thus all SCAD patients should undergo head-to-pelvis imaging. So I classify SCAD as this. This assumes they've undergone head-to-pelvis imaging. They either have SCAD and every other blood vessel is normal, or they have SCAD with typical FMD, it's usually multifocal FMD, or they have SCAD with extracoronary manifestations such as aneurysm, dissection elsewhere, ectasia, or arterial tortuosity. As you can see, there's a fair amount of overlap. The psychological aspects, and Esther may get into this, of people who have had SCAD, it cannot be overstated. This causes significant post-traumatic stress disorder in a number of people and severe anxiety and depression in the rest. We first described tortuosity associated with the so-called S-curve, which occurs in the carotid arteries. 34% of people with FMD have it, but people with SCAD have it too, and people with other arteriopathies like vascular Ehlers-Danlos, Loeys-Dietz syndrome, and genetic diseases such as that have it. And this is an artery from a man whose brother, before he came to see me, his brother just had a type A aortic dissection and had it repaired, and he lived through it. And now this gentleman has severe arterial tortuosity, which some say increases his risk of a dissection. So in order to have FMD, you have to have one of these two things. But there's a whole host of other things that occur in FMD where you can't make the diagnosis of FMD alone. And many patients are sent to me with these four things and told they have FMD. But if they don't have these two things, I can't label them as FMD, and I can't put them in the FMD registry. Now, Sister 3 here had multifocal FMD of the bilateral internal carotid artery, spontaneous coronary artery dissection of the mid, left anterior descending coronary artery, and dilation of the celiac artery. Sister 2 had FMD of the internal carotid arteries, FMD of the right and left renal artery, and FMD of the right internal and external iliac artery. Sister 1, who I saw first, had no string of beads, no areas of focal narrowing, but she had tortuous bilateral internal carotid arteries and a left splenic artery aneurysm shown here. Actually, she had 4 aneurysms. Are you telling me Sister 1 doesn't have FMD? Of course she does. She just doesn't have the string of beads. And her phenotypic presentation was without the string of beads. We're not yet able to separate those out without the string of beads as definitely having FMD unless they have a family history like this. So in conclusion, I just want to say that this PRACTA1 gene locus was first described as being overexpressed in people who have had cervical artery dissections. Next, a group of us published this paper that PRACTA1 is a genetic susceptibility locus for fibromuscular dysplasia supporting this complex genetic pattern. And lastly, in 2019, we wrote this paper, Common Genetic Variant in PRACTA1 is associated with spontaneous coronary artery dissection. It doesn't mean if you overexpress this gene, you're going to have one of these things. It just means that you're more likely to have one of these things if you overexpress PRACTA1. So if your levels are low, your risk of heart attack and coronary artery disease is high. If it's high, your risk of carotid dissection, FMD, migraine headaches, and SCAD is high. And Daniela already showed this. This is no one who's had a dissection or probably FMD should take a fluoroquinolone antibiotic. It's clearly been associated with coronary artery dissections. So I will stop here, and I'm glad to answer any questions whenever Heather thinks it's time for questions. And I'm